Hello and welcome to the latest episode in our Fighting for the Soul of General Practice mini-series, the podcast where we explore the key issues shaping general practice and healthcare in both the UK and beyond. I'm joined today by my regular co-hosts, Dr. Rupal Shah and Dr. Jens Foell, as we continue to dig into the challenges, opportunities and ideas transforming the way we think about care. I'm especially excited today, though, to welcome our guest for this episode, Professor Emily Mendenhall. Emily is well known for her work on syndemic theory, and we'll be talking with her about what this theory means, why it matters, and how it can help us rethink care for conditions like diabetes and depression, two of the most common issues seen in general practice today. Emily, welcome to the show. It's wonderful to have you on. And Ru, Jens, great to see you both again. How's everything going?
Thanks.
All good.
Lovely to see you, James.
Brilliant. Well, let's jump right in. Emily, for listeners who might not be familiar with your work, could you briefly introduce yourself? And then maybe could you tell us a little bit about what brought you to study Syndemics?
Sure. It's just really nice to have this space with you to talk about my work, but also to talk about the critical care that's happening and changes that are really happening in general practice today. And what we're up against, especially in the United States, with some shifts in funding and support for especially the people who are suffering the most. So I'm Emily, and I am a medical anthropologist and professor at Georgetown University's Edmund Walsh School of Foreign Service. I'm also the director of the Science, Technology, and International Affairs program there. And, I came to study anthropology by starting in thinking about medicine and public health and deciding it didn't really answer the deeper questions that I wanted to get to. So I trained in anthropology, but I really stay within those intersections of anthropology and medicine and public health to speak to kind of the deeper complexities that people face in everyday life. And, anthropologists are so lucky because we get to spend so much time with people, hours, days, years sometimes, to really get to know people's experiences and the challenges they face in their everyday life, which is quite different than many practitioners who see people for, in some cases, a few minutes every few months. And that's really tough when people have really complicated conditions. So after doing some work in global health, I actually went and worked at Cook County Hospital, it's called Stroger in Chicago, one of the oldest public hospitals in the United States in Chicago. And I worked there for nearly 5 years in the general medicine clinic. And it was actually through that work that I started to think about syndemics. I was working mostly with Mexican immigrant women who are documented and some who are undocumented, seeking care there for diabetes. And I realized very quickly that their suffering wasn't really necessarily about diabetes, although diabetes was very difficult, but their illnesses were very much entangled with social suffering and depression and other co-occurring struggles in their lives, from social to health to medical conditions. So that's how I came to do what I did. And then I spent time in India and Kenya and South Africa. And for years, I've been working around the world as well as domestically. During COVID, I wrote a book about my hometown in Northwest Iowa, which is now banned there. And I currently wrote a book called Invisible Illness, A History from Hysteria to Long COVID. So that's my career in a nutshell.
Wow, a lot to unpack there, and what a storied career it's been so far. So again, thank you so much for your time today. We really, really are pleased to have you on. And can we just go a little bit deeper into syndemic theory, please? Because I don't know if all of our listeners will be familiar with what that is and what it means. So could you just explain what is meant by syndemic theory and why it's so important in understanding health today?
Sure. So if you think about syndemic, you think about the synergies of epidemics. So the synergies of epidemics would suggest that there's more than one thing going around. And so it requires us to measure things differently at the epidemiological level and understand things differently at the clinical level, never diagnosing one thing, but also thinking about, okay, well, we have a primary diagnosis, but what are the other factors perpetuating these diagnoses that might be really undermining people's ability to live well? So often post-viral conditions are undetectable and misunderstood. And, I'd actually argue that a lot of my work on diabetes around the world, actually, I misunderstood some of the possible post-viral conditions that were perpetuating their illness. So why are people not getting better from diabetes? Well, often there's this unresolved trauma, possibly from people's past, that may be affecting their prolonged mental health. So just dealing with diabetes may not affect their mental health, but really helping people get through their, a traumatic experience or improve their mental health may really help their diabetes, right? And so there are all of these multiple effects by addressing multiple conditions and recognizing multiple conditions at once. And so one of the things that I really have been thinking a lot about is when we diagnose diabetes and we say people aren't getting better because they're not eating well, they're not dieting, they're not taking their medication, and we're really blaming patients. So syndemics are really about entanglement and how we peel away the layers of suffering. And when you see someone in a clinic, they present with certain symptoms, but how do we peel away the layers? It's like peeling away the layers of an onion. What is really at the heart and interacting at the clinical level? How are these, factors at the biological level actually interacting in a way that we could intervene, to improve one thing, to improve the cascading parts of suffering? So if we come back to the epidemiological level, what syndemics really are three things. One is epidemiology. One is kind of clinical factors and the interactions that occur at the biological or maybe even social and psychological level, but the interactions themselves. And then it's the drivers. So rule number one is that within a community or a region or country possibly, you can look and see that conditions travel together. So you can maybe measure comorbidities or multimorbidities at the population level. And that would indicate that there possibly is a syndemic happening among those factors. I have argued that, syndemics cannot be global because it erases the unique historical and social features that drive suffering and drive syndemics. You can't understand why one community across town is suffering from, a multiple collection of conditions while another isn't without thinking about politics or, the histories of enslavement or housing policy or food access or, historical inequalities that perpetuate and live on in the ways we structure society today, which are, of course, measured in healthcare. So that's the epidemiological level. And number two, we see these diseases that travel together across the population, but there's always these underlying health conditions or maybe biological interactions that occur that make people sicker than they would be without a co-occurring condition. So, with depression, it's actually linked to insulin resistance through the HPA axis, through glucose transport, through several features of biology. And, when you have diabetes, it's quite distressing, which perpetuates diabetes distress. But in many cases, especially at Cook County, I was really struck by clinicians who would say, well, if people kind of seem distressed or depressed, I just give them an antidepressant because I know it'll improve their diabetes. And while that is a quick and dirty solution when you're underfunded and overcommitted and you don't have enough time to really spend with people, or maybe you don't even speak the language of your patient, it doesn't really get to the root of the problem. So really thinking about what psychotherapy can do for people who have all these other features that are really struggling. And then, so we have the epidemiological level, rule one. We have the interaction level, rule two. And before I go on to rule three, let me say one other thing. There are other features that affect interactions. One of the things I found really fascinating in Johannesburg, South Africa, and Nairobi, Kenya, actually found this in both contexts, was that a powerful linkage of stigma linked to one disease could affect the experience of another disease. And that, I would argue, is a social interaction that affects this rule two of syndemic theory of interaction. And rule three is drivers. And this is the thing that's a little bit harder to measure, where anthropology can really play a central role in thinking about what drives inequality. Anything from enslavement to colonialism to, certain political leadership and political priorities to climate change to, medical care and the structure, to structural violence where institutions are situated and who has access to what and how it's paid for, all of these features that affect what that lived experience of healthcare and living healthily or living quite ill might be. So those are the three levels. Those are the three ways in which you can define a syndemic theory. And the last thing, or a syndemic, and the last thing that I'll argue or describe here, which I think is really helpful, is whenever I think about what a syndemic is, something that actually moves, which I feel like general practitioners do this very well, is really putting well-being and the interaction of multiple conditions at the center. So what do you have? Okay, well, it's easy to have a primary diagnosis of diabetes, but a syndemic is inherently the interaction. It's not the primary diagnosis. It's not the physical disease that you can put on the chart and get reimbursed for or identify or get care for. It's the interaction of those conditions.
Wow, Emily, that is a lot to unpack, and that is fascinating. And I've already feel like my mind is blown, and I'm thinking about things in different ways already. With that in mind, though, I think that Jens and Ru will probably have some thoughts to share. So can I bring you guys in here? Does Emily's definition resonate with what you see in general practice in the UK? And are you using this kind of theory in the way that you, I suppose, think about diabetes and depression, and the way that these things interact in the context of the UK and beyond?
I think that we are more in the frame of mind that Emily's described, where we notice that, for example, people with diabetes might be more prone to getting depression, but if we think about it at all, it's more like, oh, well, you know, if you've got a chronic condition, of course, that might lower your mood. I don't think that very many people working in primary healthcare really think about diabetes and depression through a syndemic framework that Emily's just described. And it's really interesting, because if I think of real life examples from my practice of people whose diabetes is difficult to control, then I'm kind of aware that often, not always, but often the social situation is difficult. And I'm kind of more vaguely aware that there may well be something like childhood trauma for some of the people I'm thinking about now, and making the link in the way that Emily describes, particularly in terms of the biochemical interactions and the sort of reciprocity of the two conditions, is not a way of thinking that we're used to in general practice.
I would slightly disagree. I think it's commonly recognized, but we don't have the levers to address it in the way the system is configured. So if we talk about the difficult to control people with diabetes, where you want to refer, you ask the specialist nurse, there is trauma, there are learning disabilities, there is social exclusion. It's just that the system is not geared up for that. There's not the psychiatry service or psychology service that says, yes, I'm dealing with the diabetics who are losing their limbs with the arterial path, so to speak. It's always other in each silo. And I think we have the thinking, we have the knowledge, we have a framework to deal with it, but that's not reflected in the way systems are set up on an individual level, but also on a more broader population level. Who's excluded, where are syndemics happening, and how do we address them? That is a missing, I think, policy and service organization are the issues there. And what you are getting billed for, where is your HbA1c dropping? You get billed for that, but do you do that by prescribing more or using other interventions?
Emily, any comment on those thoughts?
Yeah, I think maybe one of the things I would suggest, which is probably more controversial maybe in the US, although I think things are changing in this period of austerity than it would be in the UK. But in the UK, you know, like you have a school in every community, and you also have a clinic, and we don't necessarily have that in the United States. But one of the things that I would argue, along with a lot of people who work around the world, especially in resource constrained settings, is that we need to really take care for complex chronic conditions, for prolonged comorbidities like depression and diabetes is just one example, into the community outside of the clinic, because faith communities or community centers or peer support networks can really provide much more support and time than you can in the clinic. And that sort of care, I think, is something we lost a century ago that needs to come back to really care for people. And, you know, when my first daughter was born at the Whittington Hospital, it was like an emergency and we had a lot of problems. So I had someone come to my house for 3 weeks before I was discharged, but I got to go home, you know, and that as an American was outrageous, because when I had my second kid, no one called me for 2 weeks. And then I went in the clinic and I was like, I'm still alive. Thank God it's my second kid. I knew what to do, you know? And so that experience was extraordinarily different and quite meaningful to have someone just knock on your door and be like, just checking in. That kind of care, I think, is really just critical.
I think a return to that kind of care is something that's come up in many of these podcast episodes, and of course is a key feature of the book Fighting for the Soul of General Practice in various different iterations. It's quite interesting hearing you say that having a positive experience of the NHS, which of course many people do.
But
But
we were also exposed to tuberculosis and had to be an antiprophylaxis for several months. So I mean, it wasn't all positive, but
fair play indeed. I wanted to ask, you've mentioned quite a few of the different sort of social and environmental factors that these interactions, but are there any specific overlaps between these two conditions that would make these interactions more significant? Or should I rephrase that as, are there any particular social or environmental factors that make the overlap between these two conditions more significant?
well, I'm going to answer that from a feminist perspective because I work primarily with women. I've interviewed men around the world, but primarily I'm really interested in women because I think their experiences are quite different. And doing this new project on long COVID and other complex chronic conditions, it's made me think about what we don't know. There's so much we don't know about the stress system and also about neuroimmunology and how women's bodies are so fundamentally different than men's, specifically around the area that I work in and now that I live in, the 40s and 50s, when your bodies are changing so much and the escalation of diabetes and depression during that period and then comorbidities that start to layer on is pretty profound. And I think that as we dig into it and eventually have more money and time to look at, or interest to look at kind of the women's immune systems and also our kind of our neurology and our psychophysiology and how that links to metabolic dysregulation, we're going to find some really interesting things that we just don't know. And it's hard for me because I've been thinking about this so long. It's so hard to think. I mean, A1C is a stress hormone. When we think about what is diabetes, how can you disentangle it from distress in any way? It's so tightly embodied in the mind. And I think about this all the time. And I'm going to go back to speaking about women because that's what I know most of. And I think men's experiences and their stressors can be very different in some cases, in part because women are often doing a lot of invisible labor. There's a lot of microaggression that you experience every day for being a woman at work, at home, in the community, especially if you decide to have children or have children and you're managing that and work in and outside the home. There's a lot of stress. And, especially people who are living with limited income are stressed in extraordinary ways. And even if you have more income, you may still be putting your children first, maybe not just by putting food on the table and giving it to them first and maybe going without, but also you're going to put your kids' needs first. Maybe that's material needs, maybe that's time needs, and finding the time to meet your own needs, especially if you're living with a chronic condition like diabetes or if you're depressed. I mean, that period, that postpartum depression, or maybe the first 10 years of your kid's life can be really hard, especially we see more depressiveness among women who are really strapped and maybe don't have social networks. And, I have a colleague, a medical anthropologist, Emily Yates Dorr. I don't know if you guys have read her work. She has a great new book out called Mal-Nutrition, but she's brilliant. But she was telling me once, she was like, you know what, we really need to go back to communal living and communal kitchens. So like, I'll take Monday, you take Tuesday, we all live around a communal kitchen, you watch the kids so I can do my thing. But living without any, family really nearby, besides my cousin who has her own stuff, no parents, no sister close by to help me care for my kids. I really have to lean on my neighbors. You can only ask your neighbors so much. So thinking about this in terms of chronic illness, this is not something you're ever going to really be thinking about in the clinical sphere necessarily, but it comes in with every single person. My first book was called Syndemic Suffering, Social Distress, Depression, and Diabetes Among Mexican Immigrant Women. And at the end of that book, I talk about this woman, Teresa. She told me, she's like, I come in, the doctor wants to know all these problems, all these issues that I have. But she's like, but I can't talk about that. I got these 4 other problems that I want to talk about first. And she's like, she doesn't like her daughter's boyfriend. She thinks her husband's cheating on her. She's mad at her sister for this issue. She has some other things she's dealing with in the community. And those issues can be so central to what people have to solve to quiet the mind and to calm the body before they can manage what they're eating or, what they're, taking these regular medications or even exercising. So often you tell these older women, especially, you should exercise in this, this, and this, but they don't have a safe place to do it. They're not going to walk around their neighborhood on their own. They're like, are you crazy? And through these peer support groups and having a buddy, and especially in Chicago, like, who's going to do that in the middle of winter? You're going to, not only is it insecurity of like the summer, but you're going to fall on your butt and, break your leg. So, feeling safe and secure to do the things you need to do is a truly, often under-recognized element. Although I know this is something that clinicians talk about all the time, but they're limited often by time.
I really appreciate you bringing in this feminist perspective and highlighting things like microaggressions. And I loved the fact you brought in this communal living and the way that a lot of experimentation is going on around that, sort of organically around the world. And that's something I've been reading about recently as well. A lot of our listeners might not realize how underfunded, and you had a slight little line there, I think lack of interest maybe, or something around those, something like that. But there's so much more money and time is devoted to men's health historically, but also right now, than there ever has been to women's health, women's conditions, and a woman's body. So I think it's maybe just worth just mentioning that for a second, because I didn't realize quite how the disparity was, how great that disparity was. And I don't know if many people do know quite how great that disparity is if they don't work in scholarship or the healthcare profession. Ru and Jens, do you have any comments for Emily at this point?
Yeah, there's this longing for community and relationships and community cohesion, health creation. And in the UK, there's more and more hope that social prescribing can step into this, and that there are levers to address the causes of the causes. And some people really like it and think that's the way forward. Other people say this is outsourcing something medics should be interested in, and which is part of medicine. It's unclear at the moment how this is measured, how this can be generated, what kind of investments there are for area-based or group-based interventions. It's very, very interesting, but the jury is out. The hope is there to work with communities for deep and for addressing pockets of deprivation, which we see very often here in the UK.
Yeah, no, I think neighbourhood working is very much part of UK government policy, the 10-year plan, etc. But how we do that in a meaningful way, I don't think is very clear. So it's happening. Certainly, I think Jens' healthcare policy seems to also be slightly different in Wales compared to England, and I'm based in London. And so there's a big focus on neighbourhood working, but I think we're all slightly groping around as to what that means, and there's been very different interpretations. I kind of think that the interface between community groups and healthcare is a bit nebulous at the moment.
Absolutely. And there are always some examples for this group in Southampton has done that, and how can we roll it out, or this group in Sheffield, but it's very context specific and often shifting with some energetic people doing something. It takes 3 years for relationships to build, for trust to come, and then poof, it's gone again. So it's very much hoped for. Everybody speaks about the social determinants of health, but how to address it is really nebulous.
And I think that we're so used to things being rolled out. We've talked about this on a previous episode, but rolling out this kind of working is probably actively harmful. If you say this is the formula, we've seen it works in Manchester, so therefore let's roll it out to the whole country, is probably quite disastrous. So we're not used to working in this way anymore, are we? Where we allow things to emerge, working within complexity and embracing complexity. We're not used to it, which makes me feel, I'm just interested. I don't know how things are going to pan out, but yeah, it's going to be quite challenging.
Emily, let me follow on from those questions then and ask you something a bit more specific about how might syndemic theory actually change the way we design care pathways for people living with both diabetes and depression.
So I loved how you framed the ideas of complexity, because I think you are talking about one of the most critical shifts that I think syndemic theory can bring to general medical practice, general medicine. shifting how we deliver care to more collaborative care models, thinking about, somewhat precision medicine in a way that you can spend a little more time with patients. And, patients with all sorts of chronic conditions are facing a lot when it comes to coming to the clinic often. If they're working, they have to take time off work. If they have kids, they have to find childcare. But it's also paying to get to the clinic and really and when you have a complex condition, you have lots of specialists often who are trying to figure out what the heck to do with you. So in The End of Invisible Illness, I do talk a little bit about what this could look like. And maybe for the most complex conditions, especially when things are unverifiable, but I actually think this could work in any sort of chronic conditions, is having a team and everyone comes and sees the team. And so if you need an endocrinologist to pop in, they can. You need the psychologist to pop in, they can. You need the social worker to pop in, they can. Some people really need a lawyer, and that person would be available. You need, the nutritionist there and they can pop in, the general. And this almost requires, and maybe this isn't of interest to general medical practitioners, it almost requires you to be the hub and to be the organizer. And even some of the actual one-on-one primary care can be done by a nurse, but you coordinating all of the specialty care that's needed. And I would argue that legal services are specialty care, or having these, primarily representations of how people can get better. And who they need to see. Maybe it's a rheumatologist, who is it that they need to be meeting with, and that you would oversee that care, or wound care, that they can easily access someone for that care. So a collaborative care model that I'm sure you guys have thought through way more than me, but I do find that to be essential.
Ru, let me bring you in here.
No, I think so much of what you've said, Emily, is really very interesting, and particularly kind of the idea of the root cause of a problem. So if I'm coordinating this and I see someone, let's go back to diabetes, with poorly controlled diabetes, I think not many people are skilled enough perhaps to kind of think who is best placed, because the obvious answer is an endocrinologist. And I would really argue from my personal experience as well, that that's just not the case. In a lot of circumstances, they would be better off seeing a lawyer, and it's going to make the diabetes better. But being brave enough to say, first of all, go and see a lawyer is quite something, because you're really taking quite a professional risk. It's a bit out there to say that. I mean, like, probably what happens is you see lots of people concurrently. But again, we've been talking about the negatives of fragmentation, haven't we? When you do see 5 or 6 people who keep asking you to repeat your story, and, everything gets slightly confused, and there's overlap and repetition and stuff. So it's, really lots to think about, probably.
Mm-hmm.
My first thought would be that it needs to have pathways that are less micromanaged, where with less data efficiency gathering and more focusing on relationships and long-term. This is really, really risky, and I don't see it happening, because how do you know whether it will know? There's always this dual effort to do a job and then to have a meta representation of the job and being controlled and regulated. And that's the idea of hubs, and go to the diabetes cafe and then afterwards to the death cafe. That's always there. That's not a problem. Everybody has this, but where do you link it to careers, to professions, pathways, funding, holidays, etc., etc. The whole social entanglement, it becomes really, really messy, and in a way messy that in this midsection between great ideas and nothing works, there is some space, something happening. That's where my hope is, this intermediate space. You need some drivers, a lot of kindness, and fearless people.
Well, one idea, at least using a US model, is thinking about, we have these YMCAs, which are community gyms, and there's usually childcare there. There's often a workspace there. There's like a pool, there's a workout area. Often there's a meeting room, especially for elders who live in the neighborhood. or that area. But what if we also put a clinic there? What if we also put legal aid? What if they were all there? And I mean, I know I keep coming back to this, but actually having childcare available on site in that moment when you need all of those things, what if we just added those 2 rooms? That could be, in my view, very transformative because it's easy to drop in. It's easy to get there.
Can I just add to that? I live in Tucson, Arizona, and my wife and I are members of the local YMCA. And we're also obviously both massive book nerds, both being publishers. And we spend a lot of time in the public library and a lot of time in the YMCA. And of course, in Tucson, Arizona is incredibly hot, especially this time of year. It can regularly be around 40 degrees centigrade, over 100 Fahrenheit. And these 2 spaces are so vital for the community and its needs. And there's you have all these things that Emily's highlighted there. And the library seems to be almost doing more than the YMCA's in terms of offering cooling areas, to offering legal advice, having safe spaces, some childcare facilities and things like that. But it's been great to see these things in action. And again, not being an American and being relatively new to American culture and society, it's amazing to see these things that you don't say it too loud, community-driven, potential socialist democracy type programs, and it's just been wonderful to see these things in action. But it's almost like you have to kind of change the language and definition you use to talk about these kind of community-driven things here, because the moment that people get whiffed that it might have anything to do with sort of socialism, or it gets kind of jumped on. But I see these things happening all the time in my own community, often community driven by individuals, and but also many things that are being pushed by the local government. So it's very interesting to see these kind of community spaces and how that could definitely be used more, or by offering kind of a clinical perspective as well. Ru and Jens, any further comments about the topics we've been discussing so far? Otherwise, I would like to jump in and ask Emily a little bit about her forthcoming book, Invisible Illness: A History from Hysteria to Long COVID. Could you just tell us a bit more about that book, Emily?
Yeah, sure. So I had been working and living abroad for a long time. And when COVID hit, I moved to be in quarantine with my little kids and my husband. We drove out west to my family in Northwest Iowa. And I was just really struck by COVID there, and kind of how no one was masking, coming from DC, where my friends were actually working in the White House or like working on global health security, to going to a place where people are like, it's not that big a deal. Really struck me. So I ended up doing a bunch of research. My brother-in-law was leading the COVID response in our community in my hometown. Anyway, so I ended up writing on the US, which I hadn't done since my first book, Syndemic Suffering. So I wrote a book called Unmasked: COVID Community in the Case of Okoboji, which was really interesting, but it was really a lot. And so I, because, having young kids, writing a book, working on COVID during the pandemic in DC, it was just really a lot, and teaching. So I needed some time and space. So I had a student who had long COVID, and he was going to drop out of our honors program. So I've been thinking a lot about long COVID with him. And to be honest, I got into this project because my student was really sick, and I was really fascinated by his experiences. He was doing intensive journaling. We were talking constantly. And then we were doing a little project together. And I was like, you know what? First of all, I need a break. And number 2, I really want to dig into this. It was bringing up all these questions for me. And I felt like there was this whole area I didn't really understand. So I ended up applying for a Guggenheim Fellowship, and I got it. And I did not expect to get it. Now, I was just so thrilled to have some time and space. So I had a year and a half actually to just do pottery, hang out with my kids, and work on this project and think. And, very rarely mid-career do you get to take a year and a half to think and read and talk. I did more than 150 interviews. And, at this point in your career, that's like dissertation stuff. It's very unusual to have that. It just felt like an enormous gift. And I was able to think in a way I really hadn't for a long time. And I spoke to a ton of doctors, a ton of patients, academics, and policymakers about this. I gave comments to the national academies. I joined all sorts of Facebook groups and online communities to learn about what was happening. I went to conferences at the NIH. I spent some time in clinics, specifically talking to people about their clinics as well. And so I was able to really think deeply. And I wanted to write a book on long COVID and that experience. But as I dug deeper, I just realized this isn't a new thing. that long COVID may have a new name, but it has a long history. Thinking about 2000 years ago when we had the first maybe evidence of a post-viral syndrome, to the way Charcot is framing hysteria and then neurasthenia, and that these frames through history have been incredibly misogynistic and dismissive, but also limiting in what medicine can do. And it is partly a symptom of medicine that it's come to be. And even the history of chronic fatigue syndrome, which I find to be so interesting, the way in which that illness category was constructed was incredibly misogynistic and misguided. And it has created so much harm for women. And reading this stuff, which I hadn't really read in graduate school and I hadn't read broadly as a medical anthropologist, was really frustrating because I was like, how do I not know this? Where is this hidden? Even from someone who identifies as a feminist scholar of, chronic illness and women's distress, women's health. So I really just started thinking about what we needed. It just felt like there was a gap to understand the history. So I just dug in. And some of it is anthropological history. Some of it is history of literature. Some of it is history of neurology and psychiatry. I mean, it's a very, if you've read any of my work, I don't like boundaries. I think they're silly. So it's very much integrated of lots of different things that I read. And I just try to tell the story of how we think about complex chronic conditions as well as the politics. So the history are embedded in medicine and politics and society. So it's very much an American story because as I tried to make it very broad, I realized it's just so different in every context. And so, really thinking and reading broadly enabled me to tell the story in a way that I thought was really useful. So the first part is about history. And then the second part is more about disability politics and how we think about disability consciousness and how complex chronic conditions and chronicity in general of illness, living as a chronically ill person, is a central form of disability that is so invisible in so many ways. And like when we actually situate the ME/CFS, chronic Lyme disease, the long COVID story in relation to the HIV movement, the breast cancer movement, and other kind of illness movements or embodied health movements, as they're often referred to, we see that there's a different kind of activism that has been so urgently crafted and demanded, which is often digital activism, because a lot of people for years didn't have any attention. And this is why a lot of these conditions for women specifically have been underfunded, under-recognized, people haven't had interest in them, is simply because people were pretty bedbound, or, any sort of action or energy-driven activity would just make them crash. So the ability to actually engage with HIV, you can engage in pretty immersive activism until you can't. But with, a complex chronic condition, a post-viral condition, often any sort of exertion is going to put you in bed. Like hitting the streets for a protest will put you in bed for days. Maybe if you have a wheelchair, that could really improve your ability and strength to protest for longer. Often people who are chronically ill, especially from a post-viral condition, can use a wheelchair as an access point, right? Maybe they can walk, but they really need that ambulatory support so it's not exhausting for the rest of their day, or as many spoons as they need to make it to the end of the day. So thinking in those terms, I found to be really interesting. Sorry, that was a long answer.
No, Emily, thank you. That's such a wonderful way of going into the content of the books. Thank you so much for sharing that and for those stories. We're running a little short of time, so I'd just like to hand over to my colleagues. Let's start with Jens and then we'll go to Ru. I'm sure you guys have questions or at least comments for Emily, so please, over to you, Jens.
Yeah, I want to make a passionate statement for rehabilitation in primary care for all these conditions. Not condition specific, because then it takes ages to see some special people. Some will be fibromyalgia, the others will say Ehlers-Danlos exists, the others will say no, it doesn't exist, and kind of moving it away from condition or disease specific labels to knowing there's a shared common ground of social cohesion, rest, stimulation in a kind of vaguer, broader, generic way, which should be available with no waiting time, not endless assessments in primary care. I do think that would be amazing for chronic pain, Ehlers-Danlos, all these painful energy depleted, socially isolating conditions.
Ru.
I like Jens's vision. I don't think I've got very much more to add. It's a shame that we're so fond of labels, I guess.
Yeah. Emily, how about yourself? Do you have any final thoughts for today's podcast? It's been so engaging. We've discussed so many interesting topics. Perhaps do you have any thoughts or any hopes what clinicians or policymakers might take away from syndemic theory? And, do you have any hope for the future in terms of how this might change things?
I think a lot of the problems are structural, which are really hard things to tackle. I think a lot of general medicine practitioners are really thinking and want to think about these complexities and want to care for people to meet them where they are. And they don't have enough time and they don't have enough resources. I think figuring out ways to cultivate more time, just time, at the end of the day, removing labels and providing more time and more people to meet with you when you're at the clinic. I just think it could be so transformative, and it feels like it's something within reach when you think about it in a broad stance, and then you're in the middle of the clinic and you're like, how could you ever do this? How could you transform this? So I think it's a really big challenge. And I can't help it. I think it's just like because my mom was an optimist. I'm just an ultimate optimist. And I'm actually launching this new journal called Science Politics. And so I hope you write for it. You'll be hearing more about it in the coming months. And it's going to be everything from health and medicine to climate to nuclear energy, just talking about all of the politics that we keep pushing under the rug. But I think one of the things that we need to do is to think of new models to completely change the systems that hurt us. And I think this idea of the YMCAs in the US might be a transformative one, or thinking about what nurse practitioners can do and how general practice can really use them in transformative ways. And also allow them to have, the US, their power is really limited, even though, they may have more capability to get into the community. So what is possible with what we have? And also what can we completely rethink and reimagine? And so in this moment that I feel in utter crisis because of our politics, I'm trying to be hopeful in giving us a time of crisis. Just like COVID, in some cases, people are able to remake problematic systems during COVID. I feel like we're in a similar moment. And so instead of despairing, I decided to start a journal. So please write for us and stay tuned. Hopefully it'll be coming out. It's going to have a slow launch this fall, but it'll be out full-fledged in January.
Well, thank you so much, Professor Emily Mendenhall, for all your contributions today. It's been wonderful, hearing your perspectives and to dig a little deeper into these theories and that research. Very excited to hear about this new journal, especially as I'm a journal publisher myself. So we're always glad to hear new publications that are going to be sort of sharing knowledge of that nature. So congratulations and best wishes for that new venture. And again, the forthcoming book as well, Invisible Illness, A History from Hysteria to Long COVID. Any idea when that's going to be hitting the shelves?
That is hitting the shelves in January, but I actually have to make one more plug. Is that okay?
Absolutely. Go ahead.
Actually, I have this other book that's coming out actually on diabetes, which I think that you'll love. It's called Savoring Care, and it comes out next October, which is almost next month. And it's these creative vignettes about how people live well with illness and how people care for each other. So it's called Savoring Care, Flourishing Across Cultures with Diabetes. And it is a beautiful book of using creative ethnography and vignettes, and everything's co-written with participants. So it's a little bit of an ethnographic exploration and experiment, but I just think it's a beautiful book. So I'd love to give you the link to both books if you're interested.
Absolutely. Please. We can certainly share those alongside the podcast. So it'd be wonderful, and I'm sure our listeners will definitely go and check them out. Any final thoughts from my co-hosts, Jens and Ru? Well, I thank you both, as you're both obviously working doctors, general practitioners, and I appreciate all three of you taking time to join us on the In Conversation podcast. This has been another special episode of Fighting for the Soul of General Practice, our mini-series, and of course the book with the same name is available from all good bookshops and from www.intellectbooks.com or from our partner, the University of Chicago Press. So do check out the book. It discusses all kinds of issues that we discuss within these podcasts and beyond. But thank you again for your time today, and thanks to everyone who's been tuning in. We'll see you next time. Thanks and goodbye.